So now starting with the MCQs based on kidney. So in this we have two parts, diuretics and antidiuretics. We'll take 10 questions from each, and otherwise this is a long PDF, and this PDF has got how many 141 questions on based on diuretics and antidiuretics, so you can attempt all of them. I'll be attaching both the PDF. The most likely mechanism of antihypertensive action of thiazide diuretics in long term. Now in long term thiazide diuretics, they actually reduce the sodium, and due to this persistent sodium deficit रहता है, and उसके कारण there is an increase in the renin level, and this persistent sodium deficit causes reduction in the vascular resistance. It dampens the responsiveness of the vessels to constrictor stimuli, and they improve the compliance of resistance vessels. Low dose therapy with the following category of antihypertensive drugs is found to be more advantageous in long term than high dose with the same drugs. So low dose therapy with the diuretics, will not say beta blockers, alpha 1 central sympatholytics. Diuretics की low dose therapy is found to be more advantageous. If you give a high dose therapy, then it is found to have adverse effects. High dose में फिर इनके adverse effects आते हैं, जैसे dyslipidemia and carbohydrate intolerance, etc. So at low doses they are very effective. A 65-year-old male with history of COPD presents to the clinic with symptoms of glaucoma. His intraocular pressure is significantly elevated. Which of the following medications would be contraindicated due to underlying respiratory condition? Now इसमें a patient with COPD, यहाँ पे आपको समझने वाली बात है कि patient is having COPD with glaucoma. ठीक है, अब glaucoma में आप क्या दोगे? Acetazolamide, timolol, latanoprost, pilocarpine. Out of this condition, which drug is contraindicated in respiratory condition? That is acetazolamide, because acetazolamide is a carbonic anhydrase inhibitor, and it is contraindicated in patients with COPD because it can increase metabolic acidosis. So it is not to be given in it can exacerbate metabolic acidosis and also worsen the respiratory acidosis in COPD cases. So the correct answer is acetazolamide. Furosemide is preferred over hydrochlorothiazide when hypertension is accompanied by asthma, hyperuricemia, diabetes and CHF. So when the hypertension is accompanied with CHF, that time furosemide is used. It is a potent diuretic, right, and it is not a good antihypertensive. The fall in BP is because of the salt and water excretion, low reduction in the plasma volume. So that is why it is preferred over hydrochlorothiazide when it is refractory CHF. Then a patient with open angle glaucoma is treated with acetazolamide. Now acetazolamide दे रहे हैं glaucoma का. What is the primary mechanism? Acetazolamide is basically a carbonic anhydrase inhibitor. It decreases the aqueous humor production. It reduces it basically inhibits the carbonic anhydrase, leading to decreased production of aqueous humor, right? So this is how it acts. Now site of action is mainly proximal tubular epithelial cells and the collecting drugs. The following drug is found to improve the urine flow in elderly men with benign prostatic hypertrophy. Out of the given options, nifedipine, prazosin, disopyramide and imipramine, the correct answer is prazosin. Prazosin, as it is an alpha 1 blocker, right, and it decreases the tone of prostatic or bladder smooth muscles and reduces the dynamic obstruction and helps in more emptying. अगर इसकी जगह और दूसरे ऑप्शन होते तो वो होता फिर टैमसिलोसिन, अल्फिजोसिन, वो अगर होते तो उनको हम टिक करते. लॉन्ग टर्म थाइजाइड थेरेपी कैन कॉज हाइपरग्लाइसीमिया बाय थाइजाइड्स. अगर लंबे समय तक देते हैं तो इट कॉजेज हाइपरग्लाइसीमिया बाय reducing the insulin release. Thiazides, they decrease the insulin release. So this can result in carbohydrate intolerance and diabetes mellitus. Furosemide acts by inhibiting the following in the renal tubular cell. Furosemide is a loop diuretic, and it basically inhibits the sodium potassium 2 chloride co-transporter, and this is inhibited in the thick ascending limb of loop of Henle, right? A 55-year-old male with a history of renal calculi develops colic after starting with acetazolamide. Now, what is the likely cause? Acetazolamide स्टार्ट करने के बाद पेशेंट को रीनल कैलकुला था और उसको कॉलिक हो गया, तो फिर इसमें क्या रीज़न है? हाइपर कैल्सियूरिया, हाइपर सिट्रेट यूरिया, हाइपर यूरिकोसूरिया, इंक्रीज यूरिनरी pH. So then acetazolamide basically by promoting increasing the bicarbonate excretion, it increased the pH of the urine, है ना, alkaline बना दिया उसने urine को, and this can result in increase in the size of the stone. So that is the reason maybe the patient is having the pain. In the treatment of which of the following condition is thiazide diuretic not used? Thiazide diuretics, nephrotic syndrome, hyperlipidemia, CHF, hypertension. अब इन तीनों में तो देंगे, hyperlipidemia में thiazide diuretic देने का कोई मतलब ही नहीं बैठता है. So they are basically used in these nephrotic syndrome में, CHF में, hypertension में they can be used. Trimeterene differs from spironolactone in that now trimeterene and spironolactone both are basically calcium potassium sparing diuretics, but दोनों के mechanism अलग हैं. Spironolactone is an aldosterone antagonist, receptor antagonist, and trimeterene it inhibits the amiloride sensitive sodium channels which are situated on the luminal side of the renal epithelium. Now this trimeterene is basically independent of the presence or absence of aldosterone, while spironolactone is aldosterone antagonist, and it has to act from the basolateral membrane and bind to the aldosterone receptor. Let's see, it has trimeterene has got greater natriuretic action, then it's creatinine action not dependent on the presence of aldosterone, ये सही है. Trimeterene acts without the मतलब इसके एक्शन पे aldosterone के presence या absence मैटर नहीं करती. It acts from the luminal membrane side. So this is both the answers B and C are correct. Remember, trimeterene is acting from the luminal membrane side of the renal epithelium. Spironolactone acts from the basolateral membrane side of the membrane. ठीक है, ये छोटी छोटी सी चीज़ें होती हैं बट कई बार ये पूछ ली जाती हैं and you should always remember them. Coming to the antidiuretic part of the kidney MCQs, a 25-year-old male with central diabetes insipidus is stable on desmopressin therapy. Okay, now which statement is true regarding desmopressin mechanism? It increases the vascular tone to reduce bleeding. It targets V2 receptors for water consumption. It increases intestinal activity to alleviate ileus. It is preferred over vasopressin for long-term diabetes insipidus treatment due to higher V1 selectivity. So desmopressin, first of all, desmopressin is a synthetic analog of vasopressin, and it is a drug which targets the which attaches to the V2 receptors, right? And in central diabetes insipidus can result from various causes. Diabetes insipidus के central diabetes insipidus के केस में desmopressin चल रहा है. Diabetes insipidus can result of head injury or tumor or CNS ischemia or idiopathic or familial. So here desmopressin, the correct answer is this. A patient with von Willebrand disease is treated with desmopressin. What is the mechanism of action in this condition? Now desmopressin works in the patients with von Willebrand disease by stimulating the release of von Willebrand factor and factor 8 from the endothelial cells. So this is the correct answer, and by this action it increases the platelet adhesion and aggregation at sites of vascular injury, so it increases the hemostasis, so it maintains good hemostasis. So desmopressin is given IV in a dose of 0.3 microgram per kg and increases factor 8 and factor von Willebrand factor. The primary mechanism by which antidiuretic hormone reduces the urine volume is now ADH, that is antidiuretic hormone. So antidiuretic hormone will basically reduce the water excretion, water flow into the urine. So how does it reduce? It decreases the GFR, decreases renal blood flow, decreases water permeability in loop of Henle, or it decreases the water permeability of collecting duct. So we should all know that the main action of ADH binds to the V2 receptors which are present on the basolateral membrane of the principal cells in collecting duct. It increases the number of pores, aquaporine channels बढ़ाता है in the apical membrane and increases the water reabsorption, and this causes the fall in the urine volume. Select the action of vasopressin exerted through V1 subtype receptors. Vasopressin exerted through V1 subtype receptor. Now V1 subtype receptor के through it increases the peristalsis of gut. Remaining all the actions are metabolized by the V2. This is V2, this is V2. Increased water permeability of renal ducts, dilatation of blood vessels, release of coagulation factor from vascular endothelium. ठीक है. The vasopressin action mediated by V2 receptors include. Now vasopressin action mediated by V2 receptors, it increases water permeability by duct cells, it increases urea permeability, it causes vasoconstriction, both A and B. So here it binds to the V2 receptors, increases the aquaporine channels in the apical membrane and increases the water reabsorption. So there's a reduction in the urine volume, and they also increase the urea permeability in the terminal part. This in turn augments the medullary hyperosmolarity also. So the correct answer here is A and B. A 55-year-old woman treated for drug overdose with mannitol. What is the mechanism by which mannitol helps? Now mannitol is an osmotic diuretic. So it what is the mechanism? Alkalinizes urine, acts as an antidote by neutralizing the drug, reduces tubular reabsorption of drug by increasing the urine flow, inhibits renal tubular secretion. So mannitol basically increases the osmolality. It increases the osmolality of the tubular fluid. As a result, there is an increased urine flow and reduced reabsorption. Osmolarity बढ़ गई तो फिर वो उसकी तरफ उसी में चाहता जाएगा. There will be no reabsorption of the drug. What is the primary treatment for patient with primary polydipsia? Primary polydipsia के patient में just need to do water restriction. Desmopressin reduces urine volume in neurogenic diabetes insipidus, nephrogenic diabetes insipidus, both neurogenic as well as nephrogenic, and it normal individuals but not in diabetes insipidus. Now desmopressin, it acts by binding to V2 receptors in the collecting duct. And nephrogenic diabetes insipidus mein it is ineffective as the kidneys are unresponsive to the antidiuretic hormone, so it is basically used in neurogenic diabetes insipidus. Drug used in mild hemophilia. Mild hemophilia mein the drug which we use is DDAVP. Now it can control by releasing the factor 8, hence it is preferred in mild hemophilia. But there is another drug, terlipressin. Terlipressin, it is more preferred as it is more successful and has got lesser adverse effects than DDAVP. Then central diabetes insipidus best treated by which of the selective V2 receptor agonist? That is desmopressin. Desmopressin is selective V2 agonist. SIADH is often caused, that is syndrome of inappropriate antidiuretic hormone is caused by which class of drugs? So it is seen that psychotropic medications, they usually result in SIADH and involve impaired water excretion with accompanying there is hyponatremia and hypoosmolality. So these were some questions on the antidiuretics.